Needs Committee. Before we go any further with the meeting, I just need to run through the fire procedures with you. In case of emergency, there are no planned fire drills during this meeting. If you hear the fire alarm sound, please treat it as a real emergency and evacuate the building via the nearest safe escape route. The nearest escape route is via the stairs to your left as you leave the council chamber or public gallery. Exit via the door at the back of the building and walk across the inner car park to the evacuation point, which is the pavement opposite the police station. The emergency lifts can't be used in the event of an emergency. Please do not re-enter the building until you're advised it is safe to do so by a member of staff. So we'll now go to the agenda. The first part of the agenda is apologies and substitutions. We have Councillor Quirk this evening, who is substituting for Councillor Oliver. Have not heard from Councillor Lever yet, and usually he does send them if he's going to be, so we'll wait and see. Councillor Redrup is stuck in traffic. She's going to be slightly late, and Councillor Price is going to be slightly late too. Probably sums up my day today, because most of my day has been taken up by residents screaming about road closures. Councillor Lever is here, so it feels like a councillor's life. Sometimes we're on the receiving end of being stuck in the traffic that seems to be causing all of our residents issues too. If we move to, good evening, Councillor Lever. If we move to item 2 on the agenda, pages 5 to 8, which is the minutes of the previous meeting held on the 11th of September, Councillor Andre is already in my eye with her hand up. Do you have an issue with the minutes?
Just one minor point, Chair. It does mention that Councillor Jeffreys attended as a substitute for myself, but it doesn't register my apology, and I did send in an apology.
I know you did, and we will get that corrected. Has anybody else raised any issues with the minutes, or are you happy for me to sign as chair? We have it? Okay. Point 3 on the agenda, declarations of interest. Has anyone any declarations of interest? Councillors who have anything on the agenda? Are we okay? Point 4. So we do have a public question this evening, and it's from Mr. Alan Brown, who is in the public gallery. Mr. Brown, would you mind if I did something slightly different? I am a bit known for it as well. So that's cool. We'll get on well. So what I'd like to do this evening is I'm going to have a little jig with the agenda. Hopefully this is okay with the councillors. Is I will bring item 6B forward, which is James Roach from the ICB, because he can then answer the question on pharmacy, because that is on the agenda. And I will allow you to. So Mr. Roach has got a copy of your question. If you have, when he answers it, if you do want to ask something, then I will allow you to come in, but it has to be a question and not a statement. Is that okay? So you're happy with that? So we will bring you into that part of the agenda. And we also have some councillors here who I know their questions are about pharmacy and probably want an update on hospice as well. Mr. Roach has said that he will cover those as well. And I know Councillor Blake is online and he has raised a question about J-Hoots in Ventnor. So is everybody happy with that? Otherwise we're going to duplicate and we will be here a lot longer this evening. Okay, right. So we're going to skip 4. We're going to skip 5. I can feel Dem Services like, what are you doing to me? And we're going to jump to 6B, and then I will go to 6A if that's okay. It will also help, Mr. Roach, because you've got to go home by 6:30, haven't you? So I'm going to hand over for an update to yourself, and there will be questions from the councillors. A member's question, and if you could cover the question there, dentistry, pharmacy, and an update on hospice, please. Thank you.
Thank you, Chair. I'll take dentistry first. So members will be aware of the announcement today in relation to J-Hoots Pharmacy in Ventnor. I think the first thing to say is clearly this is regrettable, but unfortunately entirely predictable when you consider where the group has been nationally and some of the decisions that they've made. We've taken a view over the last couple of weeks that we needed to take perhaps more direct action in relation to the contract and the position of the pharmacy on the register. So a decision was made to remove the pharmacy from the register. That decision was made yesterday. So this is a fast-moving situation. I have briefed through Kate, and I believe you've also received formal briefings from NHS England as well. So
Just expand on that. We
Yeah.
have to remember that they're members of the public watch this meeting, and that Kate we're referring to.
Yeah,
Kate
sorry.
Harvey, who's
Kate Harvey,
Director
Director of Public Health.
Thank you.
So we've engaged and communicated on this as quickly as we could, but you'll be aware A, it's fast moving, and B, it's business commercial. So the position in relation to the group is changing quite regularly. I think the key thing to say is that whilst this has been no surprise, I think what we tried to do, particularly since March, is understand what contingencies we could put in place. So we've been working with neighbouring pharmacies in terms of how they can increase their service provision to deal with issues of continuity and sort of service disruption. We're confident that given the contingencies that we put in place, and I can name the pharmacies in a second, we will have sufficient resource in the short to medium term to meet the needs of patients who rely on that pharmacy for their medicine supply. I think I will make the point. I think we've got to give credit to those two pharmacies for standing up, but also the local GP practices as well, particularly in terms of how they've managed their prescriptions and their processing in terms of patient scripts and patient needs. So we do believe there is a contingency. This is only a position on one pharmacy currently. So clearly there's more than one J Hoots pharmacy on the island. This only relates to the pharmacy in Ventnor. Clearly we're aware of issues across the whole group. And if anything changes within that, we'll make you aware as soon as we're aware. The only other thing I would say is that recognising the reality of the situation, there was only one patient who was relying on the use of the pharmacy in recent weeks. So I think we're fortunate in that we have put contingencies in place. One patient being disrupted is clearly enough, and we're working with the other pharmacies to ensure that that patient's medication plan has been picked up. So that's the update. We're working with NHS England to sort of resolve the situation contractually. The pharmacy were made aware of the decision this morning. The individuals within the pharmacy have been made aware, and we're just managing the situation. There will be a more detailed communication that will come out, if not tomorrow, Monday, in terms of messages for patients, contingencies, who they should contact if they've got any concerns and issues, and our plans in the short and medium term. The only other point I'd make on this, Chair, is that our ability to act in real time is limited to an extent because of the PNA and the statutory structure of the PNA. So we'll need to consider how we work with pharmacies already in place in the island to maintain service, but that's our priority currently. So I'm happy to stop there on that issue if helpful.
Thank you. Mr. Brown, do you have a further question, or is that answered? Okay, thank you. And then to make this right in the right order, I will bring in the members' question. So I'll hand to Councillor Love.
Thank you, Chair, and thank you for your update. I appreciate how difficult it really is. So I just want to be clear. So I'm the ward councillor from East Cowes. So therefore I'm directly impacted by the closure of the East Cowes shop, which has not been open for some time now. And I want to reiterate what you've said. Thank you so much to the wonderful, fantastic staff, not to Jehoots, but to the one fantastic staff that tried to keep that going, who have not been paid for 3 months. And they showed a level of integrity which goes above and beyond in trying to keep that service going. But this isn't just about the pharmacy prescription for me and for them. Actually, it's called Pharmacy First. So Pharmacy First is part of a frontline port of call at the time of illness, whatever that is for that individual. That service is now lost. So that is a reduction in our frontline service for the island, and that concerns me significantly. You know as well as I do that when people go to the pharmacy, if the pharmacy prescription isn't there, then some often don't go back, which is a significant impact on public health. Bearing in mind, we've been having a series of breakings, significant breakings. It's a shame I didn't ask the question this morning but I'm now very concerned about the ability to deliver things like we've got health checks, we've got sexual health services delivered through and other home screening things, all of that is now lost because they're not in service. So, and the thing that really concerns me is that this was part of the holistic government. Let's bring services into the clinics. So in Cowes, it was in the clinic. In East Cowes, it's in the clinic. In Ryde, it's in the clinic. I'm sorry, I don't know very much about the Ventnor, so I apologise for not knowing that particular bit. But what I'm concerned about is the stress. So I have another that's caused on the other pharmacists. So I am lucky in East Cowes that I have another pharmacist, but they are under considerable stress as a result of this. So my question, so it's taken me a long time to get there, is what are we doing to resolve that? Because I mean, they're being paid for these services. I'm assuming that you're going to recover the services. There are significant contracts issued by the NHS to pharmacy services. What are we doing to recover that? And whilst I hear what you're saying about this is fluid, for me, it's not fluid. I've been seeing since before March a decline and a failure to open the services. And this is 150-ish across the whole of the United States. So a significant amount of public money. What are we doing to recover that money? And what is the emergency strategy? Because we've lost pharmacy first, essentially. That worries me greatly. And what are we doing to address that with the public out there? Those are my collective kind of questions about it. I am significantly concerned, and I would want to see a strong statement, A, thanking those workers that have gone above and beyond, but B, telling us what's going to happen. It's a lot of money that could be used in other services. And also, I'm worried about the customer message. You know, please don't give up on your prescriptions is one of my messages. Go and get them elsewhere. But they also do home services as well. Sorry, I've said a lot. I've said too much. But
I was nearly going to stop you then,
yeah,
and I
am stopping.
So, I mean, just to reiterate, and I said earlier, absolute credit to those pharmacies that have stood up, and obviously very difficult for the staff who are employed by J Hoots in Ventnor and the impact it has on them, and we shouldn't underestimate that. In terms of the financial remuneration, so pharmacy first, and you'll see from my report, is really important in terms of GP access. Pharmacies get paid as they do the activity. So on that one, it's not necessarily investment we've made. It will be based on activity that's been undertaken. What we do find with Pharmacy First is it's a great opportunity, but not all of the capacity has been taken up. So we will speak to the two pharmacies in that area to see if there's anything else we can do to maximise that Pharmacy First provision, and we're having those conversations. In terms of recovery of money, I think that's a national issue with NHS England. I think it relates to the group nationally and how they've used contracts. You'll be aware that this was a matter of debate in the House of Commons last week. So I think it's being debated at the highest levels, and NHS England will take the relevant enforcement action. But please be aware, this is an organisation nationally that's in severe financial distress. So the ability to reclaim funds will be impacted on that. All I can say is that this has been a fluid situation for a long time. We've issued breach notices. We've put in place contractual enforcement. We've worked with pharmacies locally to address the issue as well. We're the first area in the country to make a definitive decision around removal. So I think that demonstrates to you how important we take it. We absolutely have to make sure that beyond that, we don't lose service continuity for patients and it doesn't impact on access.
And just ask one quick, is that just removal just for Ventnor? What about the other stores? Because they're all closed and they've been closed for a long time. I just think that if we can deliver a clear message to the general public, use other services. I know that there's commercials and all the rest of it, but can we make sure that that message goes out really strongly, because people are confused?
So I can only comment on the decision made yesterday, but clearly there are issues with the rest of the group, and we'll of course keep you updated as to what that means for the rest of the portfolio. Given that this is new to us, we've already been given statements locally in terms of where people can access alternative services. Our GPs in the area have been really helpful in terms of redirecting patients as well. So we'll continue to give that message to patients in terms of service continuity and where services are provided.
Thank you. I just have one quick question, and it's to do with pharmacy, and it is regarding private flu vaccines. I know lots of people who need a vaccine because actually there are outside members of, not a direct member, but people that they deal with, So they need a private flu vaccine, but trying to get an appointment at the moment anywhere on the island as a private patient is practically impossible and is months ahead. You know, it's practically going to be flu season been over and done with. Is anything being done to deal with that? Because we have all our winter plans and flu plans and stuff like that. But if people can't get the vaccines, then it causes a real issue.
Yeah, so we have put more capacity in over winter, but what we're trying to do is equalise the capacity all year. So you can get the vaccination in pharmacies and GPs, and we're looking at how we can put on additional clinics to do that. So we can feedback on what's available when, and I would encourage people to raise issues if they have issues of access.
Okay, I'd like to raise an issue, please. I tried to get a flu vaccine and I can't have one till the end of November. So it's very well to say that, but if you went to go to the pharmacy in Shanklin, you have to ring them. Have you ever tried to ring a pharmacy? They're too busy, understandably, to answer the phone. And the Ventnor, not the Ventnor, so the Boots pharmacies, they only have a few appointments in the Newport pharmacy and they are literally ages away. So I do think it needs to be looked in further. It's all very well to say it, but trying to go online and book one is practically impossible.
So just on that, and this isn't seeking to deflect from the issue, we are probably the highest nationally in terms of flu and COVID vaccinations through pharmacies. So demand is really high. But what I'm quite happy to do as part of the winter plan is come back with communication in terms of if you can't get an appointment at your preferred pharmacy, is there an alternative nearby and how do we expand access? So happy to come back.
Thank you. That'd be really useful. Councillor John.
I won't name the supermarket, but there's also a supermarket on the island which is doing them, and you can book those online. Didn't seem to be any problem yesterday. I had a couple of questions about pharmacies, which was, I have to say, they were given to me. I didn't think of them myself, but I brought them here. One of them relates to people, and we've got details here of people who are going online to deal with pharmacy supplies. And sometimes those mechanisms online look a bit suspect. So I'll leave it at that. So one of the items that I was shown earlier today was shipping information with the tracking the goods that they'd ordered through an online pharmacy, which are currently sitting at Hong Kong airport, waiting to board a Cathay Pacific flight to the UK. Now, those goods, I presume, although it looked like a British pharmacy when they were ordered, are being shipped out of China. So the question I was given is, what is the supervision mechanism for online prescriptions? And what is the supervision mechanism for online medications? The person has had this delivered before and showed me the label. The label has 2 spelling mistakes on it, one of them in the actual name of the product being prescribed. That also didn't fill me with a great deal of confidence.
So I think there have been concerns around the growth of online pharmacies. I think over the last 2 years, there's been slightly more regulation nationally on that. And we have an opportunity to comment on the use of online pharmacies and highlight where we have concerns. So again, haven't got the detail on the specific regulations, but happy to come back in terms of what we can do locally versus what they're trying to do nationally. With any pharmacy, if there's an issue in terms of the service you're being provided, whether it's on the high street or virtually, I would encourage you to raise it with us and we'll raise it through the channels and try and address it. But there are concerns nationally on that and they are seeking to standardise the regulation.
Thank you. Councillor Nicholson.
Thank you. I did write to James on this. It was an issue that came to my attention, and it was an issue that I wrote to James after talking about it with the prescribers and with the pharmacists. It seems that there's a shortage in certain drugs, and whether that's a growing shortage, but when prescriptions are issued, especially repeat prescriptions, they tend to do what they say on the tin, repeat the prescription. And if that drug is not available, then the pharmacist is not allowed to substitute an equivalent. It has to be what's on the prescription. And that causes frustration to the patient, to the pharmacist, to the prescriber, because they have to keep reissuing and of course the poor patient is without their drugs. And James was going to look into it. What's the answer, James?
So I think medicine shortages are an issue. It's a global issue. It's a national issue. I think what we do find, Councillor Nicholson, where there's no alternative where that preferred product isn't available, then we almost flex the formulary, if you like. So pharmacies are allowed to sort of prescribe alternatives if they're a higher cost or not. So we've had issues of shortages where there is a contingency plan where pharmacies can expand the choice, look for other products, and are free to prescribe in those circumstances.
That seemed to fall down in the cases that I looked at. So, for example, if a 1,000 milligram tablet was prescribed, the pharmacist said they couldn't substitute it for 425 or 950 milligrams. And if there was an alternative brand available, they said they couldn't subscribe substitute it with an alternative brand. So they found it very frustrating, and the doctors found it very frustrating.
Yeah, I think some of it's availability, it's the stock being held within the shop. But I know of instances where particular products have been short, and we've almost revised the protocol to enable pharmacies to flexibly prescribe in that instance and reimburse accordingly. So I think that there is a process for that. I can't comment on that individual issue, but happy to look into it.
If that comes through in time, James, and then job done,
Councillor
I'll go back
through
and
the
ask them.
chair. Just a reminder, you're meant to come through the chair. You're not the chair, Councillor Nicholson. Just a gentle reminder. Councillor Andre, and then I would like to move on to slight confusion because you started with saying you could talk about dentistry and then went into pharmacy. So Councillor Andre, I'll ask your question on pharmacy.
My question is on dentistry, so
No,
I will hold that
horses
thought.
down. Hold that thought. Mr. Brown was happy. He's happy. You don't need to read all that out. Mr. Brown, I've already checked, was happy with the answer that you've given. So can we move on to dentistry? Of course you can. Oh, no, you need to go on the microphone and it needs to be a question.
I'll cancel then.
Sorry, we do have to be really strict. Otherwise, we have members of the public who will give very long statements. So, but what I will do for you is make sure that you are sent the very long written response that was made for you, if that's okay. Right, could you move on to dentistry, please, and then a quick update, and then we'll move on to the next section of the scrutiny section, and you'll be able to leave. Thank you.
So I'll update on dentistry. A lot of you have received updates previously. I think in terms of the paper, I think the paper reflects steady progress in terms of improving access. A more stable provider market, and I think that's been a real achievement on the island, and I'll talk about that in a second. Again, real partnership working with our existing dentists and things to be positive about in the future. So we have seen an increase in access more broadly. I think we have seen a higher proportion of band 2 treatments as a percentage of courses on the island than the regional and national average. That's good. But it also reflects that we are dealing with people with complex dental issues because they haven't been able to see a dentist for a long time. So whilst it's good, it's addressing a long-standing need. We've also seen an increase in urgent appointments for children and adults, which again is positive. Broadly across Hampshire and the Isle of Wight, we've seen an 11% increase in dental access, 24-25 versus 23-24, and we're tracking about 8% in year. The key things I just wanted to make you aware of is that we have commissioned so far an additional 62,000 UDAs, and we're just in the process of mobilising them. You'll be aware of a multi-clinic practice.
Sorry, I'm going to pull you again. Can you make sure that you explain what that is? Because we do have members of the public that listen. Thank you.
The way dental appointments are categorised nationally is units of dental activity. That's where the UDA comes from. We have commissioned already 62,000 units of dental activity for the island. Those practices are now opening and mobilised. One of them is a practice in Ryde, which will open in November, which is a 6-clinic dental practice. So significant change to the provider market on the island. And we have an additional 22,000 units of dental activity, which are currently in the process of being procured. We had a really good response to the first round. So an existing provider and 2 new providers who want to settle on the island. Should we achieve the commissioning of the 84,000 units of dental activity, that will be a 48% increase in NHS dental activity on the island. So my second point earlier was we are stabilising the provider market. 18 months ago, as you know, it was very difficult to get dentists to settle. So that's positive. And but also I just wanted to touch on a vote of thanks really to the existing providers who continue to step into the gap. So freshwater, for example, this time last year we had a closure, Denby House stepped in, the Mira have also expanded their offer on the island as well, which is really positive. So still a lot to do, but at least we can direct patients to facilities now, whereas last year we couldn't. The only other thing I would touch upon is with Kate Harvey, Director of Public Health, I think we've got a really strong partnership in terms of oral health promotion, supervised toothbrushing, and being really more focused on prevention. And the other point I think of note is that nationally there's a target to increase the number of urgent dental appointments available. We will be commissioning additional activity for the island. We will be launching an urgent dental walk-in hub from December, and we will be advertising that to people across the island as well. So we want people with urgent needs to turn up to have their needs addressed. And if I may, Chair, the support of the committee and members in publicising that would be very well received, because we have put the investment in and we just want to make sure our residents use the capacity that's available. I think everything else I can take as read. Committee will be aware that Portsmouth Dental School have now been approved by the Privy Council, so that's good news for Hampshire and the Isle of Wight. We had a really good conversation Monday with the Dean of the Dental School to talk about what that means for the island in terms of a potential hub and spoke model, if you like, but also starting to think about how can we encourage school-age children and school leavers on the island to consider a career in dentistry as well. So a lot happening, real capacity being commissioned. Still a long way to go, but I think lots to be positive about in terms of the future.
Thank you. Councillor Andre, do you still have a question? I'll take Councillor Andre, then Councillor Jarman.
Thank you, Chair. I'd just like to say through the Chair, it's great to hear that all of the things that have been talked about over the past probably 18 months now are actually either being put into place or are well on the way to happening. But I do have a further request. It has come to my attention that the care experience and looked after children that we have as an Isle of Wight council authority don't have a dedicated dentist. So I do have a request that it's looked at commissioning a specific dentist for our looked after children, because it's absolutely vital that their needs are paramount looked after. Thank you.
And I'll take that as James Roach has noted that. Councillor Jarman.
Yeah, just a three-part question, really. The one is on page 28 of our pack. I assume the rebasing is actually the ones you were just talking about in terms of the new numbers, James. The one that it says the rebasing will commence in July. I assume that's done now, happened, and they've been in the process of commissioning. The second one is at the top of the next page, where it talks about the number of additional appointments in Hampshire and the Isle of Wight, which is good to know, 30,000 appointments. I wondered how many of those were actually on the island. Sorry, we're very parochial here, but we really are. It's always nice to know what's going on in Hampshire, but it's even better to know what's going on the Isle of Wight. So if you happen to know what the number is on the island, that would be good. And the third one, which is really the crux of this, is do you feel there's any way that we could move forward with the recognizing the qualifications of the Ukrainian dentists? We've raised this before several times. We have, together with Denby House and with others there, identified a number of very well qualified Ukrainian dentists who we could bring over to the island at very short notice, notwithstanding the additional Romanians in the pipeline. But if there's a way that we can get those credentials recognized, we can help solve the problems for the island and probably other parts of the country, and deliver on many of the things that you've been talking about. And I'm looking at Kate as well here.
So we are providing better data, I think, on our Isle of Wight activity. So I think 24-25, 35,000 adults and 10,000 children were treated, but I'm happy to provide a more frequent update on that if that's helpful. And obviously I'm aware from Councillor Jarman's work with the Ukrainian population that we do have a skilled workforce that we could deploy. I have met with John Darby, who's the regional dean, before, and I'm quite happy to meet with him again if Kate would like to join, to see if we can have a conversation around what we can do on the island differently to ensure that those skills aren't lost. So happy to pick that up and come back and liaise with Councillor Jarman on that. So I think that's an opportunity we should take if it's available.
Chair perhaps could liaise with the whole committee.
Everything goes through me, and then I do, as you know, everything goes to the whole committee. I'm quite good like that. Councillor Jarman, then Joanna, and then we need to move on to the hospice because I'm very aware that we need to go on to the next section of the scrutiny. So if we can make the next few questions.
So I was going to say exactly the same as my colleague did, which is that we're a committee, so it should be. Oh, and thank you, Chair, for your remark. In terms of the Ukrainian side, you're aware that one of the Ukrainians we were looking to bring is actually one of the lecturers, spends half her time anyway at the Ukrainian dental school in the Ukraine. And of course, many of those Ukrainians who were evacuated from the Far East have been in the West, and we're very keen to see them gainfully employed if they're not needed, because they do seem to have a plethora of dentists in the Ukraine, which are quite inexpensive, by the way, but it would be very nice to get them here. And having perhaps in your conversation with the Dean to note that one of those is currently a lecturer and a teacher in dentistry in the Ukraine may assist. Thank you.
Joanna from Health Watch.
Thank you. I've just got a question about the special care dental service. So that could go to you all, James. So we've been getting lots of feedback from people that are struggling to access that service. And we understand the waiting times are over 2 years for that service. And of course, the people that use that, adults and children, have quite complex needs. So it's really worrying that the waiting times are so long. So I wonder if you're looking at that and what are your plans to address that?
Okay, yeah, so we recognise that's an issue. So one of the things that we are doing is we're getting a more regular track on waiting times now from the provider. So we have a regular meeting in terms of total waiting list, those waiting over a period of time, and how they're prioritised. Again, what can we do as a commissioner? We put some additional resource into protected sessions and additional hours for looked after children, patients with clinical vulnerabilities, and patients who might require a more specialist follow-up in a different setting. So we put the investment in. The issue, I think, with this one, again, is probably supply. And how do we create a more regular sort of workforce model? So we are looking at, so in terms of the orthodontic element, we've supported the orthodontic provider on the island to recruit another dentist. So it might be we can link in existing services better into that service. So we can think about how we can use dentists on the island. We are looking at it, and we are working with the provider to see if they can provide additional dentistry. I think, again, with this one, it's not just dentists, it's therapists, it's nurses, it's the whole team. I think we need to bolster the whole team when we look at it. But just to assure the committee, we're aware of the waits. We're looking to prioritise, put resource in where we can.
Councillor Lever, one quick question, then can we move on for a quick update of the hospice, and then we will move on to the next section of the scrutiny.
Thank you, Chair. Just regarding the supervised toothbrushing initiative, is that island wide or is that specific to certain areas? And I did have another question, but it's just left out of my head, so I'll leave it there for now. Thank you.
Thank you. Now, Director of Public Health, Kate Harvey, will answer that for you.
Thank you. The supervised toothbrushing scheme is being rolled out as part of the national rollout, focused on early years settings, so nurseries on the island, and prioritising those with the highest need. So really that scheme is going through the implementation at the moment. Very happy to come back at a later date and talk about the numbers and the evidence and evaluation from that work. But there is a very clear national model that we're following locally, and I think it forms a really important part of our wider oral health and dental health package. I would just like to take the opportunity to note that alongside supervised toothbrushing, oral health promotion obviously draws on healthy eating and diet for young people. So the work that we do in schools as well, and through our family hubs on the island for that best start in life, is a really important part of that strong foundation for future oral health throughout life.
Thank you. No more further questions on pharmacy and dentistry, because we just have the update on the hospice. And as we said, when the hospice came to speak to us, we would like a regular update at each meeting to know it is, because it's such an important issue for our island residents.
So yeah, thank you. So since the last meeting, we've been in a regular track of meetings with the hospice. Obviously, as I reflected last time, we've stabilised this year with the additional investment. So that's given us time to work out how we move forward. Really productive conversations in terms of the current model of service provision, the benefits for patients, the impact if that's withdrawn. But we're starting to have a conversation around the hospice as a whole system provider really. So what more can we do out of hospital? You'll be aware of the government ambition around neighbourhood health. I think there's a place for the hospice within that. And we've also received some evidence from other parts of the country where there are some good examples of where hospices have worked in partnership with hospitals to manage people differently. So I think conversations are being productive. We're aware very much through Joanne and Health Watch of the concern of the public on that. So we briefed Joanne this morning, and we've agreed jointly with Becky, the Chief Executive of the hospice, that we would come back to Joanne before the end of the calendar year with a substantive update on where we're going next year and what that means. So that's positive. It is constructive. We're committed to resolving it. As always, with all public sector organisations, we will have a financial challenge, but actually focusing on the right things again, the pathway right, is the way in which we can address that and get the right service in place.
Joanne, are you happy with your involvement in it? And is it ticking your boxes? Because I think that's really important. Thank you, Mr. Roach. That was really useful for us. I will happily let you go, and then we'll move on to the next part of the agenda. Sorry to do it that way, but it brought in everybody's questions and resolved those. So otherwise, we would have been a lot later than we are already running. So we will move to 6A of our health scrutiny, which is navigating support for people with co-occurring conditions, drugs and or alcohol, mental health needs on the Isle of Wight. I am taking it that all councillors have read the report from pages 9 to 22. So we're going to take that as read. And who would like to present this and go first?
Kate, you're going to go first, I think, to introduce us.
I'm
and
happy
then
to
we'll-
introduce with the public health context. And then
Lovely.
I think as a health scrutiny item, the really important discussion will be from our services that we've got with us today.
Lovely. I will let you introduce, Kate.
Thank you. As Director of Public Health, I really just wanted to note that preventing harm from alcohol, substance use and poor mental health is a really important public health priority on the island. Actually, we know it's important for people's health and wellbeing and life chances, but also the level of need for our wider services, including housing, social care, other parts of the system, and for our communities in terms of community safety and perceptions of crime. So actually, as just to give the context, as the commissioners for the Specialist Drug and Alcohol Services and as the chair of the Island's Strategic Drug and Alcohol Partnership, we've prepared the very short briefing paper in advance, really to outline some of the context. I know Nicola will talk a little bit about the scale of need on the island, and then for Mark, Andy and James really to be able to talk through what the service offers look like as the key providers and elements today.
Fantastic. Thank you, Kate. And thank you, committee, as well, for recognising this really important public health issue. We're really pleased that we've got time to talk about this with you. So thank you. So just to, as Kate said, I'm going to give a very short overview before, much more importantly, handing over to James, Mark and Andy to talk about the actual services and the work that they're doing. But the context that we wanted to give you is this. So there are just over 900 people in drug and alcohol treatment on the Isle of Wight, which is quite a significant increase from a decade ago when it was closer to 600. So drugs and alcohol is a really vital part of the work that we do within the public health team. We've got our principal, Sharon, who does a fantastic job on the commissioning of the services. And as Kate said, another key part of our role is for Kate to chair the Isle of Wight Strategic Drug and Alcohol Partnership. That partnership has a specific action plan, which includes a specific focus on co-occurring conditions because we're aware of such a huge need. As it says on the slide, around 2/3 of people in treatment have mental health conditions or needs. And that makes complete sense because we know that substance use disorders and mental health conditions are influenced by many of the same factors such as stress and trauma, adverse childhood experiences, etc. And also substance use disorders can make mental health conditions worse, can lead to the development of new mental health conditions, and can also lead to all sorts of kind of co-occurring lifestyle and societal issues. As it says on the slide, co-occurring conditions, which is the reason that it's such an important public health issue, have a significant impact, not just for individuals, but also for services and communities as well. So these can take many forms, for example, underachievement at work, difficulty meeting family responsibilities, increased risk of abuse, violence, involvement with criminal justice, poverty, homelessness, many different issues which touch on all of our public health agendas. And because of this, we know that people with co-occurring conditions can be amongst some of the most disadvantaged people in society. And they often report barriers to accessing services as well. And that's why the pathways that my colleagues will talk to you about are so important, because we need to break down those barriers and we need to build the best services we can for people with co-occurring conditions. I'm now going to hand over to James to talk about No Wrong Door and the other parts of the service.
Thanks, Nicola. So the No Wrong Door programme is hopefully something that the committee is aware about, and it's context to what we've been able to do to improve our pathways around co-occurring conditions. Over the last few years, we've benefited from about £1 million of investment, which is about putting additional kind of skill sets and to be able to provide increased access in primary care, better access to wellbeing services, improved support for older people, and peer support model, which is really quite imperative within co-occurring conditions. And the main thrust of that work is to try and break down the artificial boundaries that have kind of developed between primary and secondary care over the years. The next slide just shows what that money has been converted into. So within our 3 neighbourhoods or localities on the island, that's around 20 additional workers that are providing new skill sets around peer support work, community-based pharmacy provision, additional clinical leadership, mental health access coordinators, and direct access to wellbeing services in those kinds of areas. Just a bit of overview, just wanted to give you that kind of context in terms of the ways in which we've been able to ramp up the level of access to services moving forward. I'm now going to hand back over to Mark, that's going to get into the detail of what that pathway looks like, and I'll jump back in later. Mark.
Thanks, James. So I'm Mark Poindexter from Inclusion. Inclusion are part of the Specialist Services Division of Midlands Partnership NHS Foundation Trust. What Inclusion does is to specialise nationally in drug and alcohol use. So that gives us the ability to call in national experts to the local service on the Isle of Wight in order to improve and develop certain key areas. So an example of that would be that we've got a national pharmacy lead who's been tracking the issues with Jehoots, and we've pulled all our clients away from Jehoots, some time ago. That's helped us kind of avoid those kinds of problems. We've been working in the Isle of Wight since 2014 and have based our centre in Carisbrooke Road. Personally, I've been working on the island since around 2005 with previous drug and alcohol providers. I cover now the South region for Inclusion. So on that map, I guess the white dots are areas that I cover. So I cover 9 sites across Hampshire. I cover the Dame Carroll Detoxification Centre in Fareham, which we send a lot of Isle of Wight patients to. Previously, we were sending them to Kent. So that's a big improvement in terms of their travel times and access to treatment. And I cover the community drug and alcohol services on the Isle of Wight. It's helpful to have those local services there because quite often we're quite a small team on the island, and if we have any staff shortages or we're short of a prescriber or anything like that, I can bring staff over from Hampshire to support the delivery on the island. In terms of co-occurring conditions, this problem for people that have severe drug and alcohol issues and serious mental health concerns has been a nationally recognised problem for over 20 years. And there have been successive government initiatives and strategies that have tried from a strategic perspective to write new policies and strategy documents and guidance documents to improve this area of work. And there's been limited success with those.
And it really is about building a partnership locally to make these things work properly. We've had difficulties with levels of service fluctuating over time, and this level of cooperation being seen as a bit of an extra that we kind of stop doing when we're really busy. And we've got quite high levels of client complexity, and people are presenting with some really serious difficulties that are hard to manage. So there's always that temptation for staff to say, well, you know, I can help you a little bit, but really you need to go and see the mental health team. And then the mental health team doing the same thing with ourselves, and that person feeling like they're getting the runaround. And if they're quite vulnerable, then falling through the gaps between services. And one of the things that it's really important to identify very clearly is who is responsible for what in that situation when you've got that combination of needs. So I haven't developed this. Our clinical lead, Louise Penny, Claire Sims from the Hampshire and Isle of Wight Trust, and Sharon as our public health principal have led on a 4-pathway model. I've displayed that up there. I don't think you necessarily need to be able to read all of that and understand it. You probably can't see some of it anyway. But what that slide tells you is that we have got real clarity amongst ourselves about who is responsible for what, and also that no one is entirely responsible for any of it. So it's characterized by a spirit of collegiality, cooperation and mutual support, so that the drug and alcohol service is always helping the mental health service with their clients that use drugs and alcohol, and vice versa. Underlying that framework, we've got a number of supporting processes that make it work. So we have a trusted referral process whereby neither organisation refuses to accept any referral. And if there's any questions about a referral, we attend each other's team meetings where those referrals are discussed and the cases are allocated to workers, so that there's not this simple kind of thing, oh, this one's not suitable, we're not taking this one. We also go out together and do joint assessments for patients. And we have been delivering quite a series of reciprocal training to upskill drug and alcohol workers in mental health and upskill mental health workers in drugs and alcohol, and also to provide that to the wider health treatment system. So we've provided training to the 136 suite, the approved social workers, the Section 12 doctors, the medics, psych liaison team at St Mary's. We've written guidance documents for them in terms of, you know, where they should send which patients and so on, and what processes apply. We've offered training to all the GPs and primary care mental health practitioners on the island. And, you know, kind of jointly developed guidelines. We've got a co-occurring conditions drop-in at our Carisbrooke Road site, which is jointly staffed. We've been working really cooperatively on things like discharge planning and continuity of care. So a classic example of that would be that someone no longer needs to be in mental health hospital, but their residential rehabilitation place for drugs and alcohol isn't available for a couple of weeks. And, you know, we've been successful in delaying those discharges on occasions so that the person can go straight to drug and alcohol residential treatment rather than coming out into the community, getting into a mess and needing to do the whole process again. So I think this is back to you, James.
Yeah, back to me, it's the other side of the coin. How these services are beginning to be much more embedded with this clarity around the 4 pathways that Mark described. One of the ways that we're benefiting from that is that we now have an employed expert, a clinical nurse specialist in co-occurring conditions who's embedded in our community mental health team, who is doing a fantastic job of working with the inclusion team to support our wider range of mental health teams, not just within the community, but across things like liaison and crisis services, in terms of educating them on recognition, tackling stigma and working to embed those pathways. We've run at least 9 workshops. I think there's another one planned in October, and 700 of our staff have now been through that training to actually ramp up awareness of those conditions and those pathways. Another example of how we've worked, and this time has been with the police as well, is to provide a specialist worker who is embedded at Sandham House, provide in-reach work. And we've got some really good data coming through that the police have reported to us that they've had a 60% reduction in call-outs to Sandham House as a result of that co-occurring condition nurse specialist working within Sandham House. And it's a pilot that we'd really like to maintain if we can. We also have been doing regular multi-agency discharge events, which now co-occurring conditions and the inclusion team are fully embedded with, where we ensure that people are not just left floundering within the service over a long period. And there is a sense of kind of moving towards recovery and rehabilitation when they can step up and step down within that pathway. And there has been a process of moving people through that system, but not dropping off the cliff. There's ongoing support as they return back to the community in that area. And my final bullet point there, I feel that I've stolen from you, Mark, which is about inclusion, which is the number of people on your car. I'm going to do it anyway, which is about, there's 535 service users on the caseload for inclusion. And just to note that, thankfully, that really dovetails nicely with your data that you described at the beginning, Nicola, about the 2/3 of the 900 people that were in treatment for alcohol and drug issues that have got co-occurring mental health conditions are being supported within that service. And 40 of those patients were in that co-occurring condition pathway with us, and I'd expect that to improve as we begin to consolidate and embed these services. Move to the nethis slide. This is the kind of so what. So what's the evidence?
Sorry, can I just ask Mark, could you turn your microphone off because it actually dampens?
So the outcomes for this work are described there, and just to run through them, and then Mark asked me not to big up too much the fact that it's going to come up with a really good example of this in a second. So there you go, Mark, I have already, sorry. About improved patient experience, about the reduction in the revolving door and the unnecessary escalation of risk, better communication, clarity about responsibility between our different teams, and how we've got continuity of care to focus on the needs moving forward. And Mark, your killer example is?
Yeah, we've got a chap that, lost his business and his relationship about 6 or 7 years ago, and had quite severe drug, alcohol and mental health issues that we've managed to stabilise through this pathway. We got him suitably medicated for voices he was hearing, and he's now 18 months drug and alcohol free, and doing some voluntary work, re-engaging with his family, connected back with the church, and so it's a massive change in his life, and we really do see that feedback from people in that their experience of the service is vastly improved, and that there's a lot less feelings of rejection and being sent on the runaround for things. So we're really pleased about that. And Chair, we know that your committee members are very active in the local community on the Isle of Wight, and that they'll quite frequently come across people with drug and alcohol mental health problems, and also family members of people with drug and alcohol problems who were quite severely impacted. So we just wanted to do a slide on how to refer. We've got an online referral. If you Google inclusion Isle of Wight, we'll come up as the top search result, and you can get straight onto our website. The online referrals on there, lots of details about the service and how to access it. We've got our site address on there in Carisbrooke Road. We'd always encourage people to give us a call if they're not sure if someone's suitable or if it's the right thing for them. They can just give us a call and discuss it. We don't have a waiting list, and we don't have any complex eligibility criteria. People need to have a significant drug or alcohol problem and be willing to address it. For young people under 18, our site deals with adults. The young people's work is done on an outreach basis. So it's much better if you can phone up about young people than just sending them down. And we also work with family and carers of people with drug and alcohol problems. In addition to that, we've got the mental health crisis access routes on there. So the local access to intervention service and their contact number, and out of hours would be accessed obviously through 111. In terms of next steps, I think it's really important. We've kind of had a success. We've got the opportunity to provide an example to other services nationally from the Isle of Wight, but it's really important that we focus on sustaining this implementation and continuing to push it forward. It's always difficult. We've got some key personnel moving on at the moment. We need to make sure that they're replaced and that their replacements fully understand what we're trying to do with this and what we've achieved so far and how important it is for us to sustain it. We want to continue to widen the pathways to include other partners in the system. We're working at the moment on a 5th pathway for people with alcohol-related brain injury. So it's all about trying to make sure that people aren't falling through the gaps. We want to also increase our work to tackle stigma, which can be a really significant barrier to effective care and outcomes for people, because you will still, sadly, you know, have healthcare professionals thinking it's a kind of a choice to have an addiction problem, which obviously, if people could unchoose having an addiction problem, I'd be out of a job, and so would Andy. So we're keen to continue to challenge that perception. And I think that's us.
Thank you, and that was really comprehensive. I'm going to hand it over to the committee, and everyone's getting their hands up already, so I'll make sure everybody has a turn at asking questions. I'm going to do chair's prerogative and ask the first one, and actually it's a bit of a why. So on page 13, it starts with and local data suggests co-occurring mental health needs in this cohort are higher on the island than the already high rates seen nationally, and particularly in people entering drug treatment. So for me, I don't mind who answers that, or if it's other people, maybe Kate would like to start with that. That's why do we think that is, so prevalent on the Isle of Wight? Thank you.
I think when you look at our data on the island through joint strategic needs assessment and the intelligence we hold locally, we know that we have higher mental health needs and higher drug and alcohol needs on the island. In terms of the overlap, we would expect that to be fairly high. I don't know, and I don't think we can know whether we are better at recording on the island in terms of some of that overlap. But we do know that we would expect high rates given our background population data and level of need. I don't know if the service wants to add anything in terms of what you see on the ground.
I think obviously the Asian population to some degree plays a part. I think people sometimes moving to seaside locations from other locations plays a part. Rurality also plays a part sometimes. I think it is quite a combination of factors. When the staff that we have working on the mainland sometimes come over to support and cover, they are sometimes surprised at the level of co-occurring conditions that we have and the physical health issues that people have. So, we've put on additional training for our staff on the Isle of Wight in order to identify some of those needs and that kind of thing.
Councillor Lever, Councillor Nicholson, Councillor Andre, then Councillor Jarman, and I'm thinking about letting you in, Carl.
Thank you, Chair. I'm just interested in the 4 pathways, and my presumption, although it may be wrong, so please correct me, is that most people wouldn't start in a pathway 1, for instance. They would it would escalate. So, like, what are the first I'm interested in out of those 4 pathways? I think you said there was 900. There was a figure of 900 before. Where is that split across those 4 pathways on the Isle of Wight? And what successes do we have about preventing people from progressing from pathway 4 and that escalating? Because I imagine people in pathway 4 or would be in pathway 4 but not yet identified. I imagine that they can be quite hard to identify because they might not be outwardly presenting as in need at certain points. So I'm just kind of interested in that view of the island. Thank you.
I'm going to go with whoever's got their finger closest at the moment. So it's James.
I was just going to come back on the first point. It's 535 of the 900 that are in treatment at the moment. 900 is the wider population that have got are in treatment for drug and alcohol issues. So just wanted to correct that point. But in terms of the pathways question, I'll hand back to you.
It's an interesting question, and we haven't looked at the data in terms of how many we've got in each pathway. That's certainly something we could do. Obviously, helping to prevent people to move into greater levels of severity of their drug and alcohol and mental health is really important. And so intervening early is really critical. We do have a challenge with that, particularly on the Isle of Wight, because people are nervous of being seen attending a drug and alcohol service and of word getting round that they're in need of a drug and alcohol service. And so to combat that, we do offer telephone and online work for people. We also post out workbooks to people that we work through them on the telephone. We also provide evening appointments to people that are working and the people that would rather not come in when the service is busy. We're always trying to intervene as early as possible and make it as easy as possible for people to come in. The risk sometimes is that people don't come in until they're in severe need. I mean, occasionally we'll get someone come in who we need to send straight to the hospital because they're in liver failure, because they've put off addressing the alcohol problem. So certainly through our staff and through yourselves, encouraging people to get support early is really, really important. We have increased the number of alcohol users coming into treatment quite significantly over the last couple of years. And a lot of those are people that are coming in for a relatively short spell of treatment, so kind of 3 to 6 sessions. So people that aren't, into severe dependence, but people who are at the kind of the early stages and can recover quite quickly.
Thank you. Is that okay, Councillor Lever, or do you have to? Councillor Nicholson.
Great. So I know through our work with the Council Northwood Place Plan and Public Health that we can identify through the JSNA socioeconomic conditions that drive ill health. And I wondered if there were socioeconomic factors, identifiable factors that gave rise to this extraordinary figure. As one question. As another question, what are we not doing? You can't, you treat the symptoms, but the cause, what are we as an Isle of Wight Council, as town and parish councils, some of who have place plans, what are we not doing that if we were to do would stem the flow? Because your 50% increase in so many years is, you're fighting a losing battle here.
Very happy to take that response initially and then maybe see if services want to add. I think Councillor Nicholson, for me, it's really important for us to note that prevention starts at the very beginning. Babies, children, families, and those conditions in which our young people are born and grow and live. So recognising the work of family hubs around the best start in life, that first 1001 days critical window, and the support with our parents and families on the island as an absolutely critical element to breaking what can be an intergenerational cycle of trauma and stress, and then the subsequent health needs, including drug and alcohol and mental health needs. So I think that element in terms of the very early prevention would be 1 point from me. My second point would be around those conditions that can lead to stress and trauma, which we know can increase the risk and likelihood of harm from drug, harm from alcohol, and poor mental health. So thinking about poverty, poor housing, good work and fair employment as some of those real opportunities that can support then positive outcomes and life chances throughout. So I think you've really hit on a really important point, that our wider prevention agenda links in absolutely to breaking the intergenerational cycles that can happen here.
Thank you. Andy Hint.
Can I just add as well, there's that headline increase in numbers in treatment. But to some extent, that can be viewed as a success in that perhaps all those years ago, people weren't entering treatment. So it's not fair just to look at that as an increase in alcohol or drug issues on the Isle of Wight. It might actually, it will in fact be at least in part greater numbers accessing the treatment that's available.
Thank you, Kate.
Yeah, I think to add,
Could I have the second part of the question answered?
I think actually access to treatment for those who will benefit is a really important point. And just noting the work that's been done with primary care or with GPs specifically locally to support them in signposting and enabling people to enter specialist treatment as needed. I think we do need to increase numbers in treatment, and that's something that actually we do fairly well on the island.
Second part of your question, are you happy? No. Ask it again, please.
So what are we not doing, the Isle of Wight Council and town and parish councils, many of whom have base plans, that if we were to do, would stem the flow? So, for example,
let's build some better housing and put roofs over people's houses so they get the right start in life. That would be a good starting point, wouldn't it? If you want to know what you can do as an Isle of Wight councillor, make sure that we get and drive forward good housing.
just think that it needs to be spoken about and recorded at this committee.
Mark.
Yeah, I mean, I think it's a wonderfully interesting question, and the fact that you're asking it kind of gives us an opportunity to come back to you with a better answer. We do have a project that's just in its initiation in inclusion at the moment, where we're looking back through the course of life histories and looking for points of intervention that may have been missed in order to avoid what ultimately we're looking into at the end of it is a death. And we're just initiating this project where we try to look at what the points of intervention might have been, where someone could have turned it around, and what kinds of partnerships we might need in order to hit those intervention points. With our young people's service, we already do some of those kinds of things. So we've got really good links with the pupil referral unit where, you know, children that have been excluded from school, you know, we would then be screening to make sure that we're picking up any drug and alcohol problems with them. But I'd love to come back to you with the results of that project about what those turning points might be that we could look at.
Could I just to cut things short, could I suggest what might be done? So if you look at what's happening in the underlying causes, then for the Isle of Wight Council to have a meaningful economic strategy, and that to be replicated through town and parish councils with a string of other strategies and policies that give people hope, aspiration, increase, pull them out of poverty, give them good working conditions, living conditions. Would that help?
I think we can accept that everybody is nodding their heads. Councillor Andre, can I hand you over to your question, please?
Thank you. Well, actually, Councillor Nicholson has, I thought he'd stolen my thunder, but you've actually set me up quite nicely in terms of we have a poverty reduction strategy on the island, which is very much about addressing those causes. So one of the things, Chair, would be to link in with that. And I know that we are already linked in with that. So that is a positive thing going forward. But I think there is one part of the prevention piece that is possibly missing for me. Now, I have visited the inclusion site at Crowswood Road several times over the last few years. I am aware of the incredible and phenomenal work that you do, especially, and I know you've got very small teams but your reach and your impact is absolutely phenomenal. I really have two questions. One piece of the jigsaw that I think is missing in the prevention piece is of secondary school age pupils who I'm an ex-governor of one of my schools. I live very close by. I back onto a local park. I am very aware that there is an issue with young people who it's almost the opposite of that stigma that we've been talking about. It's almost, how cool am I? So I think I think maybe that's something more for public health to actually work with the schools to try to, all about that early prevention piece. My other question was, we've mentioned about the JSNA and stats and whatever. Now, I know certainly within the NHS, we have re-referral rates that data is kept. Do we have, because I think it's important that we do record outcomes and successes. Do we know when people have been through the pathway and effectively discharged, what the re-referral back into the service rate is?
Who would like to answer that? Who'd like to go first?
Do you want me to take the first piece and then pick up in terms of re-referral rates if the service are happy to talk about people coming through treatment? In terms of the wider opportunities around prevention, the poverty reduction strategy is absolutely key. That is definitely one of the important building blocks for health, is having young people, families and adults able to live healthy, happy, well-resourced lives. I'd suggest the other building blocks are equally important alongside. So thinking about the economic element, good work, fair employment, housing, really those secure and stable opportunities. They are not quick fixes. So for us, I would hope as a place now moving forwards, we're in a place where we have that sustained commitment and work on those really complex issues on an ongoing basis. In terms of the question around young people specifically, I know that inclusion work very closely with schools, and I just wanted to bring in really reference to some of the wider trauma-informed work that goes on with young people, particularly thinking about the factors that can be promoting resilience in the face of adverse childhood experiences. We know adverse childhood experiences can be associated with poor mental health, drug and alcohol use, and the harm that those cause. Thinking about some of the factors like participation in sports activities, having a trusted adult, the resilience factors that are being developed around our wider children's agenda, I think are really key here as well. So yes, some of that young person work's focused on drug and alcohol or mental health, some also focused on resilience and positive opportunities that protect our young people.
Happy to come in next. I think it's a really important question. I think sustained recovery is absolutely the kind of key data point for all services, mental health services in particular. So I certainly think of the people that are within the CMHT co-occurring condition pathway. I think we could be able to begin to pull that data out over the course of those treatment pathways. And I think it'd be quite interesting. I'm sort of looking at Sharon behind me as well to work in our pathways to make sure that we collaborate with inclusion to build in those sustained recovery indicators into our pathway measuring metrics, because that only then we'll be able to answer that question in the long term. Readmission rates is a sort of proxy for that, isn't it? But it would be better if we had a sustained recovery metric built in, I think. So I think we should do that work and pull out the data we can for the meantime and build on that and build it across all 4 or 5 pathways as it will be shortly. So I'll just put my colleagues on the spot there, but I think it's very doable. Yeah.
Yeah, we do currently measure representations, and Sharon scrutinises us quite closely about what our representation rates are. I've been desperately trying to find them. I can't remember them. They break down into 4 sections. So for alcohol, drugs only, alcohol and drugs combined, and non-opiate drugs. So things like cannabis and cocaine, like that, as in not heroin. So it's broken down quite tightly and is monitored closely. The only note of caution I would add is that those figures are relative to the number of people in treatment. So when we perform well and get lots of people in treatment, those numbers look a bit worse, but actually they're no worse than they were before, if you see what I mean. But I'm sure we can report those numbers quite easily to the committee.
Yeah, thank you. If you send it to me, then I've got an email that I'll forward it to all the committees so they can all see it. You can, I am watching the time.
Thank you. It's a little bit of a bugbear of mine. Obviously, we need to give these people the best opportunity for recovery. But I think I'm right in saying that nearly all the provisions that that are sort of commissioned are wet houses for alcohol. Do we feel that that is giving people the best opportunity, or should we reintroduce some dry houses?
Thank you, Andy.
We would love there to be some dry houses on the Isle of Wight. That's a short answer. It would
We
really
like
help.
short answers. That's
It would really help.
Okay, noted. Councillor Jarman, did you have a question?
So I think we have. Oh, I'm sorry.
Apologies, I think it's my stealthy gloves that meant that you missed my hand up. Just to follow on from the question and the response from a commissioning point of view in relation to the housing statutory duties, it is an area that we're exploring. It was something that was considered previously when we went out to tender for accommodation, and it wasn't an area that we were able to meet through the tender process. It is something that will be considered this time round.
Thank you, Councillor Jarman. Sorry about that.
No, it's all right. Very good questions. And first, I'd like to add my personal congratulations for what you do. I think you're just wonderful people, absolutely. And I'd like to give a thanks as well to James for hosting us when we came and visited the centre in Carisbrooke recently, Carisbrooke Road. We've heard about prevention is better than cure. I agree with that completely. Early intervention. I noted what the chair said. Yes, we have 3,000 homes for sale on the island at the moment. What we don't have is social rent accommodation, which we can provide as quality roofs over people's heads. And that's what we need. We don't need more to add to the 3,000. We need accommodation for those people. And I know many of the people who will be in that category who are at social rent level properties. But my question is this, is that while we're dealing with all of the information, it really helps for us to have a plan to go forward if we know what the goal is. And a lot of the reporting that we will hear now and that we will hear later in this meeting is about numbers. I like numbers. They talk to me. What I like though is to understand is a plan. And the plan is to have a different number, not to have the same number. And in an awful lot of the charts that we have in the paperwork today, we have a perpetuation of the same number, or, as Councillor Nicholson pointed out, a 50% increase in one of the numbers, which is not a success. So I think what would help us enormously is to have targets that say what it is we want to achieve. If we have 500 of something, and the goal is to have 400, then we can develop a plan to get from 500 to 400. If we have 500 and there's no plan, we will either end up at 500 or more. So a plea is always in all the metrics that we have, in all of the KPIs that we see, is to understand what is the goal. Now, I'm no doubt at all from you laudable people that your goal in life is to have no job. We heard that from Mark earlier. I made a note of that, by the way. And because that would be a success, that would be an ultimate success, that there is no need at all for mental health facilities or any of these I wrote down the word comorbidity because some of them are characteristics that we see, self-destructive characteristics, but addictive characteristics in many regards. So the question I have in all of this is, not for now, but please to take away, is please can you add into all of the issues that we have, what is the goal we are seeking? If there's a timeline for a 10% reduction in something, let's put it in and we can have a plan to achieve that goal, rather than simply accepting a situation that goes on in perpetuity, which we all keep coming back and saying is unacceptable.
Thank you. So I will bring you in, Kate. I'm going to bring this to a close to move on to the rest of the agenda because there is other items on quite heavy agenda in probably about 6:30. So Kate, if you can answer that, and then I'm going to bring in Councillor Love before you, Sarah, because you are really patient and he's just getting my eye constantly and he is not. And then I'm going to bring Councillor Quirk and then we will bring this item of the agenda to a close. So if we could do it in that order, please.
I will be brief, Councillor Love. Just to say, Councillor Jarman, absolutely, I think that the targets and the numbers are really important. Some reassurance, we have those in the commissioning around the services, some of which are linked to how the payment mechanisms work and the commissioning elements in terms of activity targets. I think for me, one of the really important areas that we need to think about our numbers and our targets is around the physical health of some of these individuals, because we know that actually people with mental health needs and people with drug and alcohol needs often also have the poorest physical health in our communities. So actually thinking about people with mental health needs being twice as likely to smoke, tobacco use being the single biggest cause of the 10 to 20 year gap in life expectancy that they experience. I think some targets and ambition and intent around that would really help us think about longer term outcomes for some of the most vulnerable in society.
Thank you. Councillor Love, your question. Please make sure it's a question.
Thank you. I mean, I'm grateful to be worked out of a job from HIV. Very grateful having to sit at the side of beds and watch people die in a terrible way. So that is a wonderful aim to try and achieve. Drugs and alcohol is incredibly complex. But I just want to try and answer a couple of questions based on my 30 years of working in drug and alcohol education and having a postgraduate degree in alcohol and drug education prevention, and working in Kent with KCA and Grey Zebra and all of those people. So I think I know something about what I'm talking about from a long time ago. So we have actually disinvested over time in the years that I've been in since 1992. We may well be now starting to re-engage again, but the conversations that we have around this table are no different from what I had in 1992, to be quite frank. Lots of conversations and not much change. And that's not a criticism. I'm just saying that we talk a lot, we have lots of plans, but we don't deliver. And delivering is incredibly difficult. Councillor Nicholson, what's wrong, what's missing? We have no youth service anymore. We have no youth intervention at appropriate times in terms of trigger. Okay? And the youth workers that we do have these days work for less money than I was paid 15 grand they get now. I was paid 15 grand in 1992 without the training. So we need more youth service, we need more triggers, tier 1 through, we're talking about what we called tier 3, 4 in terms of the treatment that you're talking about. But there's not much discussion about tier 1, 2, which is the prevention. Okay, and there's a lot of services missing. We had lots of workers then, we don't have any workers now at all, hardly. We have people trying to multitask, which is a good thing, but we don't have enough engagement in that. So with no youth service, we have no education advisors, which I was, which is what's missing, dedicated advisors. And it's a complex matter. Young people like to take risks. It's not just about what happens in terms of the economy, housing, etc. Young people like to take risks. And if there aren't the workers there at the right time to make that critical intervention, what we call it education then, but then it's missing. So my plea is that we start investing significant amounts of our time and effort into prevention. And I'm not talking about prevention, looking at statistics, although statistics are quite good. I'm talking about, I worked on the streets at 10 and 11 o'clock at night in Ryde, climbing through windows of squats and et cetera, et cetera. That does not exist anymore. So why should we be surprised if we don't have that core level of work that drug use goes up? And we've also not spoken about, actually, we talk about the presented problem. This is just the thin wedge. I work with older people who are in their 60s and 70s, who are alcoholics, never dealt with their problems, who deal with their problems in a different way. So there's lots of different things that, you know, what we're doing is we're dealing with crisis. That's what we're talking about in here, crisis management of people. What we need to do is switch from crisis to prevention. And that's all I'm going to say. Thank you, because I've been cut off.
Mark, would you like to respond to that?
Sorry.
I'm not sure either. I think, you know, what we can say is, Councillor Love, we do note that. I think one of the things that I have picked up, if you clearly are working with a whole generation of people, and, you know, and the work does seem to embrace, you know, looking at the slides and everything quite a lot. So, is there anybody, can I bring in another question? Is that all right?
Some answer.
Give some answer and then we'll move on.
Don't
Because I really
think I'm being critical. Sorry.
No,
I'm saying that from where we were, we haven't invested
Love.
enough.
Certainly following the Dame Carol Black review, there has been a renewal of some investment into the drug and alcohol sector, which has been very welcome and beneficial. We do have some homeless navigators now that work with the mental health team on the streets. So there's some of that work going on. But it's hard not to support your request for investment in prevention and youth services.
Thank you. Councillor Redrup, Councillor Quirk, and then we will let you go, I promise.
Thank you, Chair. Firstly, I'm really glad that you included some case studies in there, and it was useful. I'm lucky enough never to have experienced the service or know anyone who has in my immediate family, so it really exemplified what it was you do. So I really appreciated that. I wanted to ask you really quickly. We spoke about the poverty strategy. We also have our domestic abuse strategy coming up soon, and is that something that you're working on as part of that as well?
Yes, recognising the links in terms of trauma as an underlying cause of needs developing in terms of drug and alcohol and mental health, but also recognising that cycle back in terms of effective drug and alcohol support and mental health needs, linking back to reducing domestic abuse too.
Sorry, I just realised I forgot to ask the other bit. Do you work closely with the Hampton Trust?
Yes, we do. Obviously, this evening we're concentrating on co-occurring conditions, mental health and drug and alcohol, but this forms a part, obviously, of a much wider system, and we have very close links with social services, children's services, the Paragon, Hampton Trust, criminal justice organisations as well. So we're very tightly embedded within the network of all the services that I think you would expect.
Councillor Quirk.
Just two quick points, really. When Councillor Jarman was talking about targets, and there was a lot of nodding around the room, it's important, though, that targets look at outcomes, not inputs. It's very easy to say we'll work with 50 people, but it's actually how many of them successfully come out the other side. If you work with 50 people and no one comes successfully out the other side, that's not much of a result. And so it's important that we measure the right things and over an appropriate length of time. And sort of the one of the frustrations of this area is that people relapse, and you know that much better than I do. The question is, my perception is that there are different drug alcohol combinations with different age groups, and that maybe your interventions need to be targeted and tiered. And I'd just like to understand how you approach that.
we do have different programs and different, so for example, in terms of the workbooks I referred to that we post out to some people or other people who work with them on site, we've got workbooks for most drug types, you know, they're specifically tailored to people that have a preference for a particular substance or other. We also have, you know, different programs for young people as we do to adults. And also we focus on the 18 to 25 age range, which is again, you know, in that gap between, you know, being a child and being a fully fledged adult, I suppose. And we have a range of different access routes. So for example, quite often people with an alcohol problem won't necessarily see themselves wanting to associate with other people that use different substances. And so we have opportunities for those people to be seen individually to make sure their needs are met specifically. I hope that has answered your question.
Thank you. And thank you ever so much for coming to speak to us. Really appreciate it. Councillor Love, I'd just like to say, you know, we all appreciate your years of experience and how passionate you are on this subject, and your input is always invaluable to us. I would just like to thank as well for all of you attending. I'd like to thank our High Sheriff for coming along, who this is very close to her heart, and has given up her time this evening to come and listen to you. If anybody would like to stay for the rest of the agenda, I'll just let you know what's on there. We've got the report of the Safeguarding Adults Board is coming next, and then the Service Performance and Improvement Review. So you don't have to dash off, but I don't blame you if you do. So I'll just give you that couple of minutes to anybody who does want to go, but anybody who wants to stay, you're most welcome. Thank you so much. start. One, because it's cold and we need to move forward. Okay, right. Thank you, everybody. We are going to move forward to the part of the committee where we make decisions. That's hugely important in decisions. And I know that Maria and Mel are gazing at me because I have to introduce this stuff properly, apparently, and not my airy-fairy way that I normally do it. Oops, recommendation for 39. They told me off this morning and said I had to read the recommendation. Which page is it on, Marie? Right, so they told me this morning that I've got to make sure that I start with making the recommendation. What I didn't realise, they haven't put one on. So I'm going to open this to discuss the Safeguarding Adults Board annual report, which will be introduced. Could you come forward? Is that okay? That'd be so much easier. Otherwise, we're looking through Kate and then. Sorry, no one's allowed to hide in here. I want to break into song at the moment. Nobody hides baby in the corner and all of that. Come and sit up. Right, thank you. So going to let Laura introduce the Safeguarding Adults report, and at the end of this, the recommendation will be is that we make a decision to note the report. Okay, we happy with that? So Laura, I will hand to you. We can either start with Laura Gordian and then Laura Rice. The Lauras.
I'm the Laura that's going to introduce the report because I am the statutory officer with responsibility for safeguarding across the whole of the Isle of Wight. The way in which the Isle of Wight Council discharges its statutory duties is through our Safeguarding Adults Board, and Laura Rice is the Safeguarding Adults Board manager. The board consists of an executive and a wider board, and the executive advanced for you the annual report, which you're receiving today. I wonder if I could ask the committee to note that this is the first time the annual report has come to you in the same year to which it relates. Normally, you wouldn't be receiving the annual report until we're well into the next year. So this is a landmark moment and a real step forward in terms of the board's administration. For that, I'd like to note my thanks to Laura, because it's through her dedication and hard work that we've seen these changes with the administration of the Safeguarding Adults Board and the way in which it's functioning. So with that said, I'm going to hand over to Laura.
Thank you, Laura.
You're welcome, Laura.
Thank you, Chair, for the opportunity to present the report to you. We've taken real efforts this year to make sure the report is accessible to professionals as well as community members. Making sure that we're using plain English to explain the role of the board and also the functions that we carry out and the outcomes of what we've achieved in the last year. The board, as Laura's alluded to, isn't an operational body, it's a strategic body, but we play a vital role in overseeing, supporting and challenging those that do deliver frontline services. The priority is to make sure that safeguarding is a priority and that lessons are learned when things go wrong. And one of the achievements of the 24-25 report is the introduction of learning briefs, which is something that we've brought in so that practitioners and those working on frontline in frontline roles, excuse me, are getting, sorry, excuse me, are getting access to that learning at the earliest opportunity. It's vital that when things do go wrong, we capture that learning and we make sure steps are taken and the board has the assurance that those errors won't happen again. We also, in 24-25, had our first conference, which was the first conference we'd had since COVID. We had over 100 professionals from 30 different organisations attend, and it was an amazing networking opportunity for professionals from across the island to get together and discuss those important safeguarding topics and themes. We've also introduced what we're calling an unexpected death protocol, whereby the board are reviewing every single island unexpected death. The reason we do that is so that we can capture learning at the earliest opportunity. And if we think something's not worked, or there's a process or a procedure that's not being followed, we can capture that very quickly and we can hold agencies to account. So we've done some big work in that area. I was pleased to see around the table earlier, many of our board members, Health Wash, Inclusion, Public Health, the ICB, as well as adult social care, are all regular members and regular contributors to the board. So I thank those that were in the room earlier as well for their contributions. But I'm happy to take any questions that you may have in the report.
I have a question for you first. Would you like a Strepsil? Are you okay? Because I do have them in my bag. I've got a whole medicine cabinet here if you need any. Who has a question, please? Councillor Andre and Councillor Jarman.
Thank you, Chair. I can say I did actually attend the safeguarding conference, and it was really brilliant, the innovative way that the information was delivered. So congratulations on that. My question revolves around on page 46 of the report. It says data is showing that more work is needed with care providers to promote good practice, to encourage a culture of openness and support professionals and the public to speak up when something feels wrong, with community groups to understand barriers to reporting and to understand gaps in learning for frontline staff. Can I ask how the strategic plan, I'm not clear looking at the strategic plan, how it's going to address those areas? Thank you.
Are you referring to the new strategic plan 2530? Yeah. So we're still in the progress of developing our delivery plan on how we're going to achieve those outcomes. We had a planning meeting this week. So we're still in developing on that delivery plan. I think one of the key things for us is those community groups and accessing those groups and knowing who they are. That's a barrier for us and that we're working close to. And we've had a lot of conversations about what we're calling silent individuals. So people that don't regularly access services, they're not known to social care, they're not known to health, they're not regularly seeing their GPs. There's a big gap for us in terms of knowing who those people are. So one of the big things we're doing, particularly we've got Safeguarding Adults Week coming up shortly, 17th of November, put it in your diaries. We're hosting an afternoon tea session with community groups that's being led by the voluntary in the community sector, so that we can make sure we're engaging with those communities so that they know more about the board and we can know more about their local issues. So we're working as hard as we can to close some of those gaps down.
Could you send me an invite for that and I'll forward it to the committee, please? Thank you.
Sorry.
Just to follow up in terms of the question around care providers and promotion of good practice, the Safeguarding Adults Board has a representative from the Isle of Wight Care Partnership, who are the, if you like, trade group for care providers on the island. So information is fed back routinely through that route to their members. Not all care providers on the island are members of that organisation. So across adult social care, we run regular forums with all care providers across all sectors, and safeguarding information is relayed through those routes as well as through link commissioners. So that link is very clear and driven by the activity undertaken by the board and its subgroups. In relation to the culture of openness and support for professionals, the work that's undertaken by the board is replicated by each of the 3 statutory partners. So by myself in adult social care, by colleagues in the ICB, and by our colleagues in the police, to ensure that we're promoting, so far as is possible through every contact, the fact that safeguarding is everybody's business. And if people are quiet about it, we can't help. So that piece of work is also part of the DNA of our services on the island now.
Thank you. Councillor Jarman and then Councillor Nicholson.
So I want to carry on with the theme I had earlier, which was about targets. And I'm very much looking forward to the 25-30 plan. And I hope it's got lots of targets in it. For example, if in 24-25 we had a number of 12, then the plan for the next 5 years might well be 8620. That would be a good plan. And then you could develop the implementation to achieve those targets. And that's the key thing. We need specific objectives to deliver against and to measure the success of the plan against in the future. So please make sure that in the plan there are lots of numbers, lots of deliverable dates, and we can understand exactly what it is expected that the plan will deliver. Thank you.
Laura G.
Councillor Jarman, if we ever got to a position where I was reporting 0 in relation to safeguarding, I'd be doing a terrible job. Safeguarding
More going home with no job.
Safeguarding works in the other way. The more we see, the more we know, the more we learn, and the safer people are. The enemy of safeguarding is silence, and low levels of reporting are of great concern to myself and to the Care Quality Commission. Similarly, in terms of the number of concerns that we receive, we track on a regular basis the conversion rate from those concerns that are coming in to how many result in investigations and to how many result in other activities. Each of the partners across the board will have their own metrics by which they are required to regularly report. And from an adult social care point of view, I do that through my annual safeguarding returns as part of the national reporting scheme. That's vested in my organisation rather than in the board. So the targets that the board will be looking to bring through in the strategy are likely to be high level. I suspect the level of detail that you're seeking won't appear because that's out with the gift of that board itself.
I think if you have them you're feeding them into the strategy, then the strategy should say what it is delivering on. And if it's delivering on your numbers, that's fine. They can append them at the back. But we need to know what the outturn from this is. What, for the investment of time and energy that we put in and that you put in and that lots of other experts put into this, what is the outturn? What is the result that we're expecting that to deliver? Thank you. Thank you, Chair.
Councillor Drummond, can we note though that this is the Safeguarding Adult Board annual report? It is not the Safeguarding Adults strategy. They are two different things. That's okay. Yes.
I'm afraid, Chair, through you, I must come back on that point because the Safeguarding Adults Board is a board providing oversight and strategy, not delivering services. It is not for the Safeguarding Adults Board to evaluate or report on the data that is the data of the local authority in the same way it isn't for that board to report on the data that is the data of the Integrated Care Board. The adult social care safeguarding data is reported nationally through annual returns that are publicly available. Those annual returns are shared with the Safeguarding Adults Board at the same time as they're published.
So I have to come back because I'm not looking for the
Councillor
data. I'm
Jarman.
looking for the results, which are the targets that we're working to.
Councillor Drummond, can we please stick to this is the annual report? Okay, noted.
Thank you. If I could, I'd like it discussed in public at this committee. Looking at pages 46 and 47 and the graphs there, you've got what to me looks like abuse with intent and abuse that might not be with intent. So the neglect and the acts of omission are 4 times what the others are. And if you look at the next graph on page 47, location of abuse, in residential care homes, it's 3 times what most of the others are, and in the own home, it's 3.5 times. So is that with or without intent? What are the drivers of this abuse, and how can it be identified, and how can it be tackled? I don't know whether that's a question for this committee or not, but I think there are important things to air in public.
And thank you for pointing that out. I think what I tried to address in the report is I didn't want people to be scared, and when they read those statistics about the amount of abuse and neglect, particularly within residential and nursing homes. And so I did make it clear within the annual report that you should expect to see higher numbers of safeguarding referrals for those categories of people, because those are people with complex needs, and it means those homes are doing their statutory duty in reporting that, as Laura Golding said just now. High numbers of safeguarding concerns is a positive, because it means people are recognising abuse and they're recording that, and then steps can be taken. Lower numbers would be far more concerning, and I point to the graph specifically that we'll talk about modern slavery. We receive very few safeguarding referrals, or sorry, the local authority receives very few referrals in relation to modern slavery. Does that mean it's not happening, or does that mean it's not being recognised and it's not being reported? So that is an area of concern rather than the neglect and the acts of omission. What we do know from the local authority data is that the large majority of those referrals referred to neglect and acts of omission are things like falls within residential homes or medication errors within residential homes. They have to be reported. That's a CQC requirement that they have to be reported. So they are recorded. And the way in which they're recorded is they go under as an act of neglect or act of omission. So some of it is skewed by the way it has to be reported. Hopefully that answers that.
Laura Gordian.
And just to build on that narrative, in terms of what's reported here, it also includes self-neglect, where there is no perpetrator, the individual is unable to meet their own care and support needs. And we don't know about them because they've not come to the surface in terms of our services. So I think it's a bit more complicated than intentional or unintentional. We're certainly talking about harm, but harm with a small h rather than a large H in all cases. Where there is harm with a large H, those actions are taken and appropriately taken, as well as reporting concerns in relation to residential care homes and care at home delivered by agencies to the local authority safeguarding team. Reports are also made to the Care Quality Commission, who have responsibility as the regulator for those services. So we tend to always see nationally high numbers of reporting in care settings because of the vigilance, because of the professional scrutiny that is undertaken in those areas. So not unusual, not surprising, and not concerning in terms of levels of reporting.
Thank you. I'm going to move on if we are happy to vote that we've noted this report. Show of hands, please, that we've noted the report. Because I want to give, I know Councillor Price has got to go at 7:15 and Councillor Lever's got to go at 7:30. And I would just like to make sure that we give the right amount of time to Laura Gordian, who we are very lucky with this committee that she takes the time to give us more factual and on-time data than any other committee, and I know that there's lots of work goes into this to bring this to it, so we need to make sure that we give a suitable amount of time for this report. So I hand over to Laura Gordian, then I will open to questions.
Thank you, Chair. And for the first time, I believe, this report also includes the data for public health. So it really is a data set.
Hey, I thank you too.
A data set that's reflective of the totality of this committee's responsibility. By way of introduction, I think this is the third time you've seen this report now. We've maintained consistency in terms of layout for you, new additions relating to public health and the activity that's been undertaken within Kate's service area, but largely the key changes are in terms of the data that you'll see within the report. I don't propose to take you through it in any detail. I'm certain you will have read it. There are a couple of areas I would just like to draw to your attention, and those areas are contained within the performance report at the appendix. Forgive me, I've just scrolled down and it's turned into the most massive page. I can only see a fraction of it at the time. I just wanted to draw to your attention the graph on page 70, which relates to the total number of people being supported by adult social care. That graph gives you two-ish years of data, but data over 3 financial years. And I think it's important for this committee to note the top line with the triangles on, forgive me, I can't tell you what colour it is this year's data. We are seeing an increasing number of people presenting to adult social care for support, a significant increase, certainly on 23-24, and a marked increase on 24-25. We anticipate that trajectory continuing to increase throughout the remainder of this year, and it's largely linked to people needing more care and support than they have before. For information for the committee, for the first time, I'm now supporting over 20 people who are aged over 100 years old. I think that's an incredible statistic for any local authority, but over 100 people now, over 20 people now supported who are aged over 100. Significantly more people supported aged over 20 than that piece of data. So yeah, just wanted to draw that to your attention. Similarly, on page 71, there's something a bit wonky with the graph around the 2024-2025 data, a marked drop off in terms of number of people living independently at home in March. I believe that to be an error, but I've taken that away to look into because I haven't had the opportunity. I'm hoping we didn't lose about 300 people who were living independently at home in March, but we'll double check that position. And the final piece of information I want to draw your attention to is the bed and breakfast data on page 75, number of households with children in B&B over 6 weeks. We have changed the way in which we're supporting families in bed and breakfast accommodation. We've benefited from the council's investment in alternative accommodation to support people in households with children who need emergency or temporary accommodation. And what you'll see from the data in front of you is we're holding steady at one family exceeding 6 weeks. Our aim is no families in bed and breakfast at all, let alone exceeding 6 weeks, but a marked improvement in terms of performance. We've recently, in addition to the work we've undertaken around children in bed and breakfast, looked at our total number of rough sleepers, which is on page 74 for you. We've seen an increase in the number of people sleeping rough, not homeless, sofa surfing, but actually sleeping on our streets. And in order to tackle that, we've created a new post within the team, tenancy sustainment officer. The purpose of that role is to support people who are our most entrenched rough sleepers, to change the way in which they think about accommodation, to move into accommodation, and then to support those people to sustain their tenancies in the longer term. What we've seen is our most entrenched rough sleepers moving into accommodation and not being able to cope. So additional support is definitely required in that space. We're out to advert currently, and we're confident that we can make an appointment to be able to take forward that piece of work. I've no other information for you. I'll hand over to Kate.
Thank you, and then I'll open to questions.
Thank you, Laura. Just to note that this is the first time that the cover report has included public health, and the indicators and data were previously set. And the first thing I'd like to suggest to committee is that I take away and look at whether there are some alternative indicators and ways of presenting the data that may actually give us something more valuable to look at committee on an ongoing basis. Looking through these, I think people will have recognised much of the data hasn't been updated since the last quarter. And I think it's valuable for us on occasion to look at the annual indicators. I think there may be alternatives that we can look at that will give us a little bit more valuable discussion here.
So that would be really appreciated, because the point of this report is to make it very live, so we can have a meaningful discussion. That was the one thing that we didn't want the quarterly report, because otherwise the data was already passed and gone. I will open this to questions. One of the things I do think we need to note from previous, one of the things I hadn't realised was how we were recording and dealing with people who were families in bed and breakfast, and why a few years ago we weren't actually saying that there were children over 6 weeks. That's because people would hit the 6 weeks mark and we'd move them into another bed and breakfast. Fundamentally, that was not right, and it's not what should have happened. And I'd really like to thank Laura Gordian for ensuring that that is real data now. That is not a family that, you know, are being moved around from 6 weeks and let's move them on. So that is a really good improvement. And thank you, Laura. You don't have to reply, but I do want to ensure that the committee is aware of that and the work that you've done. Who would like to ask the first question?
I did pause, giving my colleagues a chance. So I don't think it'll surprise any of us that as we're doing less assessments, the number on the waiting list has gone up. That seems to be a direct correlation. Whenever we do more assessments, the number waiting goes down, and whenever we do less assessments, the number goes up. It seems to be very demand driven. If I turn to the document which covers Home Finder, and I look at the number of households in temporary accommodation, to me this is a classic example of where we report data but we don't understand the consequences of it. We have 250 households in temporary accommodation, which is of course a tragedy, but what we don't have is a target for for what we're going to do about it. It doesn't say within 3 months to reduce it to 200, within 6 months to reduce it to 150. There's no end result. And to my knowledge, I think 4.5 years I've been here, it's always been around the 250 number. We've never achieved any impact seemingly on the result, and there doesn't seem to be a plan to do anything about it. Could I ask, is there a plan to introduce to each of these charts a target and a date which will give us the direction of what it is we want to achieve, and therefore in the budget planning process, which we were discussing again at some length today, yet again, we will know that if we want to get to 200 rather than 250 within 1 year, what resources and budget we will have to put against that line item to achieve it. A very, very simple input-output model. Is it possible to have that? Thank you.
Chair, the short answer to that question is no. These are demand-driven services. People become homeless for reasons that are multifaceted, and the ability to say, as a local authority, we're going to stop people becoming homeless is certainly beyond the scopes of the world in which we currently operate. There's been a substantial disinvestment in prevention services, and that lack of prevention is what results in what we see, as is a global pandemic, or as is a cost of living crisis. All of these things impact on the number of people who become homeless. Those homeless people, those households, are the households that present needing temporary accommodation. I could tell you my trajectory would be to see zero. That will never happen in my lifetime. I'm absolutely certain of it. And I think if we're going to put targets in place, they need to be smart, they need to be specific, they need to be measurable, but they also need to be achievable. And given the fact that these are demand-led services, that just isn't possible. If we use Home Finder as the example, Home Finder is an optional service. The 2,690 households registered on Home Finder have chosen to register on Home Finder. Some of them have accommodation that they wish to move out of for a variety of different reasons. Without implementing substantial changes in how Home Finder works, we wouldn't be in a position to control those numbers. And if we were controlling those numbers, we'd be curtailing the choice and control that local residents have over where they live and how they live. So I think I absolutely take on board your point, Councillor Jarman. I'll go away and I'll look and see if there are trajectories we can put in place. But with demand-led services, it's really difficult. It's not a straight input-output model.
Am I? So this feeds into the budget planning process, which is absolutely critical at this point, given all the other pressures we've got. And you've talked about the financial pressures you've got too on this area. If we cannot show that an investment leads to a result, for example, a reduction in the number of people requiring temporary accommodation, we cannot take that saving to our 151 officer, as I think we all know, don't we, looking along the table, and say that that is a cashable saving that we can actually invest in homes to provide to those people, to reduce the number, to save money here in this budget by spending it wisely on providing those social rent housing to take people off the list. If we can never have a mechanism to reduce these numbers, our 151 officer will simply sit there, as he's done for 4.5 years, saying, you're not giving me a model with any cashable savings, and I will not allow you to invest in it. That's what the roadblock that we're in. So we need your help, Laura, here to win this budget argument, to make those investments in social rent housing, to take people and reduce these net needs. We'd absolutely need your help.
And Councillor Jarman, I hear what you're saying. I'm afraid I'm going to be unhelpful. The investment in relation to temporary accommodation is in swapping one version of bricks and mortar for another version of bricks and mortar. The majority of my spend is in meeting need. It's not an investment. It's not a cashable saving. the needs of people are what I need to prioritise in terms of the spend of the budget that's allocated to me. Similarly with adult social care, if you're asking me to make cashable savings, you're asking me to cut the support that I make available to island residents. And I'm afraid that's a line that I'm not prepared to cross.
That Councillor Jarman. Councillor Jarman, we are going to move on. Councillor Quirk.
We're charged with giving value for money, which we may well be doing, but you can't see it because there's no benchmarking about how we compare with other authorities with comparable demographics to ourselves. Is there benchmarking information available? And I think that would be very good to have in reports that you're regularly looking at to see whether we are actually delivering value for money and where we're giving the best value for money and where we're maybe giving not such good value for money, and whether we can learn something from Blackpool or someone else in a particular area. But that's not here, and I think it would be really good if it was here.
Councillor Quirk, there is national benchmarking. It's undertaken on an annual basis by the Association of Directors of Adult Social Services. No, it's through their spring and autumn surveys. The autumn survey tends to be more focused on a specific area, but the spring survey provides an awful lot of information. The data from those comparator exercises is published nationally. It's released. I'd be delighted to bring that to the committee in future years. Historically, it's been shared with the cabinet member and with cabinet as that data has become available. I think it's a very good point and I'm happy to take that on board.
Thank you, Kate.
Yeah, I'm happy to pick up in relation to public health. We don't have the same benchmarking in how we use the public health grant at the current moment. I suspect that may change in the future. So again, to echo Laura's discussion, I'd be more than happy to bring that discussion. And particularly for us with the public health grant, obviously we're looking at investing in areas that by and large give us social return on investment. So the question is, how do we get the best set of outcomes and return on investment across different programmes, rather than perhaps an absolute value of spend? It's a relative comparison.
Thank you. I'll just give the list so you all know where you are and you've not been missed. It's Councillor Lever, Councillor Andre, and then Councillor Nicholson. Councillor Lever.
Thank you, Chair. Just taking us back to the households homeless or in temporary or emergency accommodation. The charts in terms of like the 1, 2, 3, 4, 5, 6 bed, they across the year kind of all around the same sort of markers. But in terms of not registered or home finder, there's been a kind of steady increase there. And what that says is households who do not meet the qualifying criteria to register with home finder or a new entrance service. Can I just understand that a little bit better? Or are we getting more people applying who just don't meet the criteria, and then therefore why are we suddenly seeing more people applying if they don't meet the criteria? That kind of.
We're seeing more people applying who don't meet the criteria, and we're seeing that by virtue of changes in the housing market on the Isle of Wight. So people who've previously been able to access private rented accommodation simply can't access that accommodation now because it's not available to them. So it's indicative of that change in the housing marketplace.
Can I just add to that though, that it's unaffordable as well. That's the big point at the moment, that there might be houses available, but they are becoming completely unaffordable.
I guess my quick follow up to that was how do we help those people, because they're clearly slipping through a gap there now, aren't they?
And that piece where my statutory duty ends and my ethical and moral duty begins is always a difficult one. What we've done through the Household Support Fund is increase the amount of advice that's available to people. We're shortly tendering for our advice, information and guidance contract. The contract we have is expiring, so we need to do something different in that space. And we're intentionally increasing the amount of support available around housing advice, housing information and housing guidance in that space, so that we're filling that gap. We're really lucky our voluntary sector partners step into that space and do a fantastic job, as does the Living Well Early Help Service commissioned by Adult Social Care to sit across both of those services. So it's a gap, we're aware of it and we're trying to close it.
Thank you. Councillor Andre.
Thank you, Chair. One of the things that really highlighted and drew my attention was the 5 strategic risks in adult social care and the 2 in public health. But one I would particularly, it's a little unfair because I know the context of it, but it seems like we're sort of banging our heads against a brick wall, which is strategic risk 10, which is current score 16, and we don't seem to be moving towards a target. The pressure points we're very well aware of, Chair, but under the mitigation activity, maintain engagement with the ICB and review underway of the shared care arrangements with the ICB. Is there any movement forward trajectory on that? Because it does seem like it's been ongoing for some time.
I suspect it's made me older and greyer than any other part of my portfolio. And at this stage, due to the substantial changes that are taking place across integrated care boards, that activity is not progressing as fast as we as a local authority would like it to. With our ICB required to make 48% of savings across its delivery model, that's taking priority for them. They're trying to unpick and unpack what that looks like. We continue to engage on a regular basis, and I'm supported by both the Chief Executive and the 151 officer in those discussions. We have met at highest level possible locally and continue to pursue an outcome in that space.
Thank you. Councillor Nicholson.
Yeah, just following on from Councillor Jarman's comments, I fully understand what Councillor Jarman is driving at, and I think it's a really good point. It's a constructive comment to make, and I understand exactly where you're coming from, Laura. You've got to deal with what you've got, but Laura and Kate are both directors of the Isle of Wight Council, so the problem doesn't have to stop with you. What Chris has asked doesn't have to stop with you. I think I'd be very surprised is as an Isle of Wight council with access and collaboration with town and parish councils and place plans, that there isn't something that we couldn't do to help drive down your targets.
If I make a start on that, referencing back to Councillor Andre's point from earlier, actually, in relation to the poverty reduction strategy and thinking about some of our wider strategic action on the island that underlies many of the driving and causative factors that relate to the need and demand that come through, particularly Laura's service areas. And I think the targets, and mindful that public health are supporting with the metrics to show progress in delivery of that poverty reduction strategy. I think the targets there will be really helpful, and being able to potentially share some of that progress through in a very different way to a traditional performance report would be helpful.
So, Chairman, so in that case, it might be possible to come back with a positive response to Councillor Jarman's proposal.
Thank you. Thank you all for your time on this. And I think the recommendation is that the committee note the operational and financial performance of the Adult Social Care and Housing Needs and Public Health Directorates. Are we happy for that? I'm going to move on to the work plan because I've got a suggestion and I want to see your opinion on the suggestion for the next meeting, if that's okay. So at the next meeting, we are going to have brought the domestic abuse strategy. So I wondered what your feeling is on the scrutiny part of that meeting to actually to bring in to this committee to scrutinise them all the parts of what would be your journey if you were going through a series of domestic abuse. So I know it's very close to Sarah that there is lots of people that we could invite in to have that discussion. I think it's the thing that we don't bring into the room, do we? So I think it will make the domestic abuse strategy real and more live if we can actually have the members who will, those parts of the service that Kate, would you be, but I do need to check if the committee would be happy with that. I'll bring Sarah in first because it has been one of the things that she's been very hot on. just your feelings if you're happy to do.
And by, do you mean providers? Is that
Yes.
what you're meaning? So like,
Yes.
Paragon,
Yes.
Paragon.
Yeah.
I suppose there's two elements to it, really, two main elements. Without going into the wider stuff, there's Paragon, but also Hampton Trust.
Yeah.
Would it make sense to invite both of those
Yes.
providers?
What do you think, Kate? It's an idea for.
Yeah, very
Scrutiny.
happy to. And I'd be quite keen that we could, if committee were interested, we could retain some discussion around the strategy delivery plan as well. So we pick up some of the strategic work as well as the operational service elements. And I don't know how that works between the scrutiny function and the core policy and business decision.
And I think it might merge slightly, but my feeling is there is so much has gone on in changes with how we deliver help under domestic abuse from, you know, years ago when it was the WOW service and stuff like that. I think the conversation we haven't had is how is the, you know, the service being delivered now? You know, what does it look like and how can we question, you know, where are the gaps, or, you know, maybe it's a perfect, but you know what I mean, isn't it? If we can get all those agencies in the room who play a part of it, it might be quite interesting as well to ask the police to come along to see how they would react if they get a call of a serious, and how they work with the other agencies to deal with that. I just think it would be really useful for this committee. It might, the lines might get slightly blurred when we go into the strategy, but I think that whole sort of what does happen and what's, you know, what is really happening on the ground within those services. Would everybody happy to do that? And I think that should be the only thing, because actually it is such an important topic and has had so many changes in the years over who delivers that service. And I know that lots of councillors have not been satisfied and happy how the service is run, but actually we haven't been able to have a point of contact to discuss that. So if you're happy, I think that if that would be all right, we put it on the work plan. Councillor Nicholson.
I think it would be interesting to look at it from a behaviour point of view. So much as with the police some years ago, I remember the Serenity Initiative, where they looked into the driving behaviours of the top 20 repeat offenders and found that most of them were rooted in ACEs. So if we're going to look at this, then could we look deeper into the behaviours that drive such issues?
I think that's why it's important to have the Hampton Trust here as a perpetrator programme to really speak to them about their experience dealing with perpetrators.
Make the whole strategy, you know, to actually take that first part, that scrutiny section, to discuss that, see what's happening, and it will just make it more of a live and a meaningful evening, I think, if that's okay. Are we happy to do that? And I'm always asking the impossible of Mel, so I'm sure Kate will help you organise this. Kate, are you happy with that?
I am, and just noting that obviously, as with safeguarding, domestic abuse is the responsibility and many services and partners across the system have a role to play. What we won't be able to do is bring in every part of the system to one discussion. So just note that we could bring maybe Paragon and the Hampton Trust for a discussion around the specialist service end, and perhaps in the strategy conversation pick up around the other levels of need and opportunities.
I think we'd really like the police here as well.
And the police,
It
yeah.
would be really important the police come,
Yeah.
because, you know, most of the time they are that first point of call, and it would be nice to hear from the horse's mouth how they now deal with that.
And can I also note, unfortunately for committee in advance, I won't be here. I had unfortunately pre-booked leave before I even started the role. But Nicola, who you met this evening, will be in attendance and we can support with the services. But I am mindful that I won't be here. We may be able to arrange some additional support. Well, I will miss it as chair of the Domestic Abuse Strategic Partnership. I will miss being part of that
I
discussion.
know, but it's taken a long time to get to this point, and we've got so few of these meetings left that I think it's really important that we bring stuff. Councillor Jarman.
In terms of the forward working plan, one of the issues that came up in an informal meeting of the PFR today was the role of the service committees in the budget planning process. Now, clearly, we have within our remit adult social care, public health and housing, the directors of each of those areas are bringing forward plans now with line item detail and mitigation options within that remit, which is clearly within the remit of this committee. So it's really a question in terms of the forward working plan. What role do we feel that this committee should have in reviewing or inputting recommendations to the PFR within the scope of our remit?
Okay, so one of the things I think I need to forward that the discussion that was on the last PFR meeting was that as part of now this committee is, you know, the cabinet role is not there, that actually we'd have star chambers and things like that, and PFR actually decided that that part of the budget process would be coming here. So my understanding is, and when I have the agenda setting meeting next week, that I was going to ask that to come on to December, so like a little star chamber, and you can all be part of that. So that's part of the discussion I'm going to have with Laura, Kate and Mel next week when we're doing agenda setting. And it was something that was put forward by PFR to Chris Ward as well. So we could ask Chris Ward to attend.
I was at the PFR meeting this morning and the informal briefing, and I wonder whether Chris Ward should be involved in those conversations more heavily. He is our Chief Finance Officer.
Yeah, no, the
and
plan
we do
is
need to ensure that we're consistent with all service committees.
yes, it will be, but it was made at the last actual PFR public meeting that would be happening. And Chris Ward nodded his head. I'm not sure if he nodded his head because he wanted to always just, I had him in like in the whites of my eyes, but he definitely nodded his head. Yeah, whites of the eyes. If nobody has any further questions, thank you for your attendance this evening. Thank you for all our outside bodies. Thank you to those of you who carried on what is a very cold council chamber, and thank you to our member of the public. And you stayed till the end. I am impressed, sir. Yeah, I'm impressed. I'm impressed. Mine, if you see, I keep moving like this. See, I've got the fidgets now, but yeah, they are truly uncomfortable. It's not as bad as being a school governor though, because if you're a school governor and you start at primary, you end up sitting on very tiny little chairs and then have to go through the whole time, which gets even more difficult. Thank you everybody for your attendance. I will now call the meeting to a close.